Hi, my name is Heidi Carson, and I'm the Housing Director for Covenant House Alaska. Today I'm going to talk to you about trauma-informed care. This is going to be a brief overview of trauma-informed care, and for those of you that are direct staff, you're going to receive an in-depth video that will be more lengthy, more descriptive, and have more techniques that you can use and put into practice, and you'll receive that later. So trauma-informed care, or as we see it, is kind of an art. We are looking at a person and seeing their behaviors directly influenced by their past experiences, and responding to them with a heightened sense of understanding and care. So with that being said, we'll begin with our training objectives. In this training, you will learn how trauma shapes the way we perceive ourselves in the world, that everyone has trauma that they've dealt with in one way or another. Not everyone deals with trauma in the same way. And without having positive attachments, self-regulation skills, and resiliency, children who've experienced trauma may have higher risks of mental, physical, and socioeconomical disturbances. Understanding our own triggers helps us and our youth cope with understanding theirs. So let's talk about what is trauma. So the definition of trauma is an emotional response to a terrible event like an accident, rape, natural disaster, and immediately after the event, shock and denial are typical. Longer-term reactions include unpredictable emotions, flashbacks, strained relationships, and even physical symptoms like headaches or nausea. While these feelings are normal, some people have a difficulty moving on with their lives. Psychologists can help these individuals find constructive ways of managing their emotions. So now we're going to talk about why being trauma-informed matters. And I think the most important parts on this slide are the last two, which are actual quotes from our youth. So I'll go ahead and read those to you. When staff asked me why I was so angry, I didn't realize it myself. I thought I was just talking when they saw my words as violence. In my family, that's just how we talk. I don't want people to think that I'm violent. And the last one, taking the time to ask the right question changes the youth experience and the staff's. All the frustration subsides when we garner understanding by digging deeper. We all learn something here, and that was from one of our staff. Components of a trauma-informed care program. So there's 4 kind of areas of components where trauma-informed impacts our programming. So those are creating a safe environment that feels inclusive, building relationships and attachments for our young people, fostering resiliency so they are empowered and they know what to do next, and supporting and teaching emotional regulation so they can learn about their coping skills and adjust them and get away from some of those maladaptive coping behaviors. We're going to talk about a few types of trauma which vary slightly. So a lot of people have heard about post-traumatic stress disorder, which is very common in people who've experienced things like war or traumatic events. But what is frequently overlooked is complex post-traumatic stress disorder, which it occurs with children who've experienced trauma constantly and throughout their childhood. And we find that that is a lot of our youth. So it's called CPTSD. There's also vicarious trauma or secondary trauma, which our staff experience and hearing some stories or seeing our youth go through some really hard things. And then acute traumatic event. So everyone has been through something traumatic in their lives. Recently we experienced an earthquake which sent a lot of people into trauma and trauma triggers, and every time we got an aftershock, they definitely felt it, and heart rate increased, and they got kind of nervous, and they thought another earthquake was happening. So that is an example of an acute traumatic event. If you haven't experienced an earthquake before, I would say that it's also like getting in a car accident, or even a minor bumper-to-bumper car accident can feel like a really traumatic event. This next section, we're going to talk about trauma responses as seen in behaviors. So there's some overt reactions, covert reactions, and then how these kind of translate into behaviors. So some of those overt reactions have to do with blow-ups, meltdowns, violence, destruction, or hypervigilance. Hypervigilance can mean a high state of arousal around noises or location or around other people. Covert reactions have to do with numbing, isolation, depression, self-harming, or avoidance of people or situations. Some of these behaviors can translate to sleep disturbances, disordered eating habits, maladaptive coping practices like self-harming or using drugs and alcohol, academic disruption, and interpersonal or relationship struggles. And right now I'm going to have you watch a short video and I'll be back with the rest of the presentation.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, "Dr. Burke, have you seen this?" In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
In this section, I'll be discussing the study that was conducted called the Adverse Childhood Experiences Study, or known to some as the ACEs study. So this study was conducted that took a look at a longitudinal effect of trauma on young people. So it was a 10-questionnaire study in which people were ranked from 1 to 10 in regards to these things that they had experienced. And what they have been able to show is that the higher number of adverse childhood experiences, the more likely people were expected to have some social, emotional, economical, cognitive development differences or disruptions, and adoption of risk or health risk behaviors. They experienced disease, social problems, perhaps, things like smoking and drinking too much or drug use, and even early death in regards to how far these scorings could affect their health and the general outcome without any sort of interventions. So in talking about those interventions, your next slide is about ways that we can respond to trauma. First, we need to understand and respond appropriately to the behavior. Our next is be patient, thoughtful, and creative. None of us works here alone, so consult your team. Have agency practices in place to support being trauma-informed. Be calm, and never is helpful to add fuel to a fire. And pay attention to the environment. Decide whether or not there are factors that are in your control to be able to alleviate stress. So this might include maybe a youth is having a hard time and they just had a telephone call in the lounge and they were screaming, and there's a lot of staff telling them like, hey, you need to keep it down, or you can't talk like that, or we don't cuss here. And what needs to happen for that young person is a safe space to vent, because whatever occurred, they're obviously really heated about it. So telling them that they need to be quiet in that moment where they're feeling so many powerful emotions, it may be more appropriate to ask if they want to come to the room and talk to you, or to ask if they need a moment of privacy, and respecting this idea that whatever they just experienced was real and it was hurtful and they're going through some things. So there's some small adjustments that we can do. Being patient is critical, and being creative is to be that thoughtful and to come up with alternative solutions for what young people can do instead of the things that they've gotten used to doing can mean the world to them. So now, to give you an opportunity to practice some of what you learned, we're going to try an exercise. So your friend brings home a dog from the pound. We've all had this happen. And they say that the dog, they suspect it's been abused. It shies away from the touch, it hides from loud noises, it whimpers, maybe it goes potty on the floor. I want you to think about how we respond to its fear. So think about what we do, and think about some things that you wouldn't do. And I'll be right back with you. All right, so let's talk about some of those approaches that you came up with working with an animal that's potentially been abused. So some things that we would do would have to do with speaking softly, letting the animal come to you when it's comfortable, offering treats, everybody likes food, backing off when it appears nervous, give pets or belly rubs if it lets you, move slowly, and get down on its level. Some things that we definitely wouldn't do would be rushing the animal to pet it, yelling, "Oh my God, puppy!" picking it up immediately, corner it to play with you, get it to submit to the will because you're the alpha, smack it if it gets the least bit aggressive, or drag it by the collar towards you. So how are we able to adjust our approach for an animal that may or may not have been abused, but we can't do the same for people? And that's how we want you to think of each of the youth that walk through the door. They're a puzzle. We don't know what's happened to them. We don't know where they've been. And the only way that we're ever going to find out is if we ask those questions. So let's talk about trauma-informed consequences. We think of these as teaching opportunities. We value failure and trying, and then failing and getting back and trying again, and providing a safe place in which to do so. So trauma-informed consequences. We're going to talk about the difference between punitive consequences and trauma-informed consequences. So punitive consequences have to do with the removal of services, privileges. They're based off of retribution. They're one size fits all. It's the same for everybody. They're predictable. They seldom have connection to the actual infraction, and they're also ineffective. And if you need an example of that, just take a look at our jail system. The next is trauma-informed consequences. So these are designed to demonstrate a lesson, fosters understanding, they're thoughtful and tailored to the young person, they add something to enrich the young person's knowledge and experience, they normalize making mistakes, and they give an opportunity to make amends and do better in the future. So now it's your turn. Which is the most trauma-informed intervention? Every time a youth is getting ready for bed, Daisy starts to become disruptive. She gets loud, she starts arguments, and she makes up excuses for staying up late. The staff on shift can take the following interventions. A, tell Daisy to get to her bed or she's going to have extra chores in the morning. B, have Daisy sleep downstairs. C, give Daisy an observation of her behavior at bedtime and ask her what is going on. Or D, instruct Daisy to go to her room and not come out. What would you choose? So this is actually a really common scenario that our staff go through. So if you chose option C, then you are correct. In this real situation, the staff informed Daisy of her behavior and compassionately asked her what was going on. Daisy disclosed that bedtime for her back home was when she was abused by a family member. The staff person asked Daisy if she would feel safer reading a book next to staff until she started to feel sleepy. Daisy jumped at the chance, and bedtimes became much less of a struggle for Daisy and for the staff. Daisy began to learn to prepare for bedtime in ways that decreased her fear and anxiety. Reading at bedtime became a positive thing for her to look forward to, and after this technique worked, Daisy began to bond more closely with the staff and even take them up on the suggestion of practicing meditation together. So let's examine our own trauma triggers because everyone has one. So you need to know your triggers. Take 5 minutes to write down your trauma triggers. Here are some examples. Loud noises or yelling, getting called names, seeing violence, hearing racial slurs, hearing stories of sexual abuse, working with survivors of domestic violence, being around a lot of people or strangers, or having your gender or sexual identity disrespected. We'll give you a moment to think about those and then we'll come right back. So now that you've written down your own triggers and kind of took the time to look within yourself and figure out what were the things that may trigger you, think now about how you might respond to that or how it's going to be important when you're in the field and you don't necessarily have a lot of time in the moment to work with or adjust your next approach to the thing that just triggered you. So we're going to discuss some of those methods of dealing with our own triggers when they've happened. One of those methods that we discussed is called tapping out. Staff use this technique when they've been triggered with a youth, or maybe even when they're starting to just lose patience, or they're tired, or they need a moment. So tapping out literally looks like going to one of your coworkers and saying, you know what, I need a minute. Go in the break room, go ascend the rock wall, go do what you need to do to take that minute to get your mind right. Because it's very important that we don't demonstrate poor values communication to our youth by unloading on them when we ourselves are triggered, or having a breakdown in which their youth become our caretakers when we're crying in the middle of the lounge because you've been triggered from name calling or something like that. So you need to figure out what your triggers are and decide how you're going to adjust your experience with those, and maybe even deciding a partner or a buddy who works the floor with you, or whom you have a good relationship with, where you can go to and hold each other accountable when you notice that you have been triggered. In this presentation, you should have learned how to deal with your triggers, how to deal with the triggers of our young people, and understand that everyone has experienced trauma. Trauma definitely colors and shapes the world in which we live, and sets your behaviors and their behaviors up for future behaviors due to the past that you have experienced. Without things like positive attachments, self-regulation, and empowerment, or building of resiliency, young people who've experienced a lot of trauma in their lives have a really hard time being able to move on from that. This is so important for how we're able to serve the youth at Covenant House, because we recognize that all these young people just walking through the door have experienced a myriad of trauma. And it's up to us to take a look at each youth as a puzzle piece and figure out what's happening to them and how we can show them a different way. Using trauma-informed care practices matters to us, because we're going to have an easier way, even though it takes more time. And even though you have to be more thoughtful and more creative, it serves the youth better so that they learn for the future and not just the time that they are with you there in the shelter. So we urge you to read up. There's a lot of videos, and talk to any staff person that's been here for a while to discuss those different approaches to trauma-informed care, whether it be techniques or suggestions or any of their experiences, so that you can learn how to do it better. Trauma-informed care does not reside in a book that is black and white. It really is an art form, and it takes time to be thoughtful because it has to be adjusted for each individual. So I hope you have learned a lot from this, and feel free to ask any questions.